Well, thank you all for being here with us today. Welcome to the CCR-ETA 2110 Recipients Evaluation Webinar Series, which today will be hosted by the Washington State Evaluation Partnership, or WSEP. WSEP is one of two national evaluation training centers of the Community Health Workers for COVID-19 Response and Resilient Communities, CCR program. We are a partnership between organizations and individuals that exist to conduct a national evaluation of the program and provide evaluation-related technical assistance and training supports at 2109 grantees. My name is Elizabeth White. I use she, her, hers pronouns. I am the Evaluation Training Manager for WSEP and a public health consultant based in Denver, Colorado, the traditional territories and ancestral homelands of the Ute, Cheyenne, and Arapaho peoples. Before we dig in today, I'd like to begin with a digital land acknowledgement. Since our activities are shared digitally to the internet, let's please take a moment to consider the legacy of colonization embedded within this technology, our structures, and our ways of thinking we use every day. We are using equipment and high-speed internet not available in many Indigenous communities. Even the technologies that are central to much of the art we make leave significant carbon footprints, contributing to changing climates that disproportionately affect Indigenous people worldwide. I invite you to join us in acknowledging all of this, as well as our shared responsibility to make good of this time, and for each of us to consider our roles in reconciliation, decolonization, and allyship. Next slide. Our webinar today will offer space to discuss cost-effective analysis. This webinar provides an overview of what a cost-effectiveness analysis is and its purpose. It will also explore how to bridge existing efforts and data to tell a similar story of impact. Our objectives for today include that we will understand what cost-effective analysis is and some of its forms, examine benefits and limitations of such analyses of demonstrating impact, explore examples of cost-effectiveness research that examine the impacts of CHW initiatives on COVID-19 response, identify alternatives to cost-effectiveness research that a 2109 site can use in sustainability discussions, and engage in a reflective or applied practice to examine our individual CCR evaluation efforts and support attendees to take away at least one concrete action to integrate into their CCR evaluation activities. Next slide. In order to make the most of our time together today in values-aligned ways, I have a few Zoom and shared space considerations. First, for Zoom, I ask that you please mute yourself when you're not speaking. Please change your name in Zoom to the name you would like to be recognized by. And please put any questions in the Q&A function to be answered by our speakers during the Q&A time today. And please know that we are recording the presentation. For the shared space, I ask that we respect different opinions, experiences, and perspectives, while recognizing that we're ultimately rooted in shared struggle and goals. We aim to lead with curiosity and openness today. I ask for your presence and invite you to treasure the shared time together. And finally, you know your needs best, so please take care of yourself in any way you see fit. I will now hand it over to our moderator for today's webinar, my WSEP colleague, Winnie.
Hello, everyone, and thank you so much for joining us today. My name is Usefulness Bakshi, and I go by Winnie, and I'm a consultant at John Snow Research and Training, Inc. Okay, so let's talk about what today is going to look like, the introductions and the flow of today's webinar. We have a very exciting lineup of 4 speakers who will talk to us about the different aspects of cost effectiveness. And we expect each of these presentations to take about 15 to 25 minutes each. Once we've heard from all of our speakers today, we'll have a Q&A session for the remaining 25 minutes. And as our speakers present, we really encourage people to use the Zoom Q&A function to post your questions. This feature helps us keep track of all the questions that are being asked. We'll do our best to answer as many as we can towards the end, and we really look forward to engaging with you. All right, so let's get this party started. Our first speaker today is Ms. Catherine London, and here's a little bit about her. Ms. London has over 30 years of experience in developing policy in the areas of healthcare financing, payment reformation, reform cost containment and quality improvement. As a principal consultant at UMass Chan Medical School, Ms. London has led a number of initiatives to effectively deploy and sustainably fund an array of traditional health workers. These projects have included providing technical assistance for an initiative that funded community health workers to boost local health departments, COVID-19 response in Connecticut. She's also worked on supporting advisory groups developing certification standards for doulas and CHWs in Connecticut. She's worked on developing models for dually certified doulas and recovery coaches in New Hampshire. Ms. London holds a master's degree in health policy and management from Harvard School of Public Health and a bachelor's degree in applied mathematics and biology from Harvard and Radcliffe colleges. Ms. London will be presenting for the first 25 minutes, and she will be introducing us to what cost-effective studies are, exploring their benefits, their limitations, and she'll also be providing a case study of a similar assessment. So please join me in welcoming Ms. Catherine London. Yeah. Catherine, the floor is yours.
And if you're going to pin me to the screen, I think that would happen now. I'm Catherine London. As Winnie said, I'm going to do two pieces. This presentation has two distinct parts. So I'm going to start with just a very brief overview to cost effectiveness analysis. And then I want to talk about a study that, a project that we did when I was at UMass Medical School. And I have since left there and I'm an independent consultant, but I'm speaking about a project that was done there, and I'll give some credit to that as we get to it. But first, just a very brief overview of cost effectiveness analysis. Okay, next slide. So I wanted to start by just pointing out, we use the term cost effective frequently when we're talking about things. We say, oh, this is a cost effective approach. But cost effectiveness analysis has a very specific technical meaning in the analytic world. And so I just want to be really clear on what that is. So I copied in the CDC definition, which is that cost effectiveness analysis is a way to examine both the costs and the health outcomes of one or more interventions. It compares an intervention to another intervention or to the status quo by estimating how much it costs to gain a unit of health outcome, like a life year gained or death prevented. So what this means is the way cost effectiveness is used, it's largely used by funders or to think about, okay, if there are a lot of ways to achieve an end. So in this context of COVID-19, you can think of many interventions that would help to prevent the spread of COVID-19 cases. From a funder's point of view, the funder wants to know what is the best way to spend their money. If they invest in one type of intervention versus a different type of intervention, how many more cases can they prevent using this set of interventions versus that set of interventions? So it's really kind of at a macro level of looking across all the different ways of achieving an outcome. Next slide. So very briefly, this is the calculation. I'm going to start at the bottom of the slide. The result of a cost effectiveness analysis, as we mentioned before, is the cost per change in health outcomes. So the net cost per case of disease prevented, net cost per COVID case prevented, for example, net cost per death averted, net cost per additional year of life gained. And how you do this, going back to the top of the slide, the data that you need to know the change in the health outcome that you're looking for as a result of the intervention, the cost of the intervention, and the cost of the treatment that you don't need to provide because the people didn't get sick as a result of your intervention. So it's looking at that lens. And then the calculation is you take the cost of the intervention less the treatment cost averted, the cost that you didn't spend because people weren't sick, and divide that by the change in health outcomes. So, okay, that's the technical part of this. I'm going to jump to an example because I think it's a lot easier to see in a real world example. So next slide. This is an example of a contraception analysis. So I pulled this from a published study this is one, just a small part of a much larger table, but just to pull out a few small examples out of the larger set of all the different contraceptive methods, I think helps to really see how this is used. So in this example, the first column shows 4 different methods, a copper IUD, a vasectomy, diaphragm, and oral contraception. The next column is the total cost of this method, and total cost here includes the method, the cost of the actual device or procedure, failure cost, meaning the cost of getting pregnant if the method fails, and the cost of any side effects, the cost of treating any side effects. And when you look at the cost column, you see that IUD and vasectomy are by far the lowest cost. Diaphragm is next, and then oral contraception is much more expensive. Then when we look at the effectiveness column, and in this case, they define effectiveness as the annual rate of not becoming pregnant over the course of 5 years. And when they do this analysis, vasectomy is 100% effective, IUD is almost 100% effective, oral contraception a little bit less, diaphragm a little bit less than that. Okay, so you can see the range of cost and you can see the range of effectiveness. And when you do the math, it shows that IUD and vasectomy are the most cost-effective of these methods, but diaphragm is more cost-effective than oral contraception, even though oral contraception is more effective than diaphragm, but because diaphragm costs so much less, it is more cost-effective. So now this is, and again, this is from looking at a macro point of view. If you were deciding on contraception for yourself or, counseling a client, you would take into account the effectiveness and the chance of side effects and all of the things that would affect that individual. So, this might help to look at this, but it's really not made for personal decisions. This is more like, if you were starting a new program in a country and you only had so much money, where would you want to try to aim most of your funding in order to prevent the most pregnancies, I guess is the way you would say that. So that's sort of a real world of how cost effectiveness analysis is used. Next slide. So then the question comes up, have researchers used cost effectiveness analysis to evaluate community health worker services? And the answer is rarely. Generally, so again, cost effectiveness analysis is used to look at a number of different ways to get to the same end. Community health worker interventions tend to have a lot of outcomes. There's usually not one single outcome that you're focused on. And so evaluations of community health worker interventions tend to look at other measures, and I'll get to those in a minute, that reflect sort of the broader scope of the outcomes that are influenced by the community health worker intervention. But it is possible to do a cost effectiveness analysis. And I found a few, not very many, but a few. So here's one example that I pulled. This is an intervention that worked with clients, community health workers worked with clients to help them bring diabetes under control. And the intervention included home visits and education classes, exercise, nutrition, that kind of thing. So it was the intervention was a number of different things actually put together. And the evaluators calculated that the cost of the intervention ranged from $11,000 up to $33,000 per what they call a quality adjusted life year gain. So how much did it cost for the intervention to produce one additional year of perfect health in one of the clients? So that's the way to calculate, to look at that number. And the evaluators looked at a number of different interventions, and they said that there is sort of a rule of thumb that if interventions fall under the threshold of $50,000, cost of $50,000 per quality adjusted life year gained, then that's considered a cost-effective intervention. And so they said, okay, look, the community health worker intervention cost only $11,000 to $33,000. That's less than $50,000. They called this a cost-effective analysis intervention. So that's kind of the way that you look at this. You know, they're looking at community health worker interventions for diabetes control relative to all the other things one could do to help people bring their diabetes under control. Next slide. So, but as I said, I mean, that's an unusual thing, that most evaluations of community health worker services use different methods and different approaches. And I just provided a few examples. So, you know, there generally is a big focus on outcome measures such as improved asthma control, improved diabetes control, reduced risk for cardiovascular disease, that kind of thing. And then if you want to look at financial measures, rather than this cost effectiveness ratio that is, you know, sort of direct, has to be compared to another intervention that is trying to do exactly the same thing. Generally, we look at broader measures of financial effectiveness. So direct cost savings. So specifically the medical costs averted, to the extent that community health workers help people to not get sicker or to get better. The medical costs that were not incurred because the people didn't get sick. What are the savings associated with that? There's a calculation of return on investment, which is the amount of savings resulting from the intervention for every dollar spent on the intervention. And then another one that we often try to do is a social return on investment, which is the idea is that if people are healthier, they can work more, they're able to work more days, they can go to school more days, caregivers can spend more days doing whatever else they were going to do if they are not taking care of a sick person. And you can measure social return on investment in days, or to the extent that there are working days recovered, you can do an estimate of the dollar value of that. Those working days. So those are the kinds of measures that are more typical for community health worker evaluations. But so I thought I'd put that out there. And I should mention, we actually, my UMass team created an Excel tool for calculating these kinds of measures that's available on the Families USA website. And there's a link to that at the bottom in the appendix. Okay, so that's the very brief introduction of to cost effectiveness analysis. And now I want to go on to next slide. A project that we did recently, and this is really, it's not a case study in doing cost effectiveness analysis. It's a case study in what do you do when you don't have the data that you wanted to have to do the analysis you wanted to do. Next slide. And I want to credit the Connecticut Health Foundation funded this, dreamed it up, you know, saw it through, directed the whole thing. Incredible, kudos to them. And my team, my former team at UMass Chan Medical School. So I had worked with the foundation at the beginning to conceive of this project and put it in place and sort of see it through. Lisette Victoriano did a lot of project management and technical assistance. But the work that I'm going to show here, the survey research was done by the Office of Survey Research, led by Viri Belchada and Melissa Carapanos, and the cost analysis was done by Yara Halassa Rappel and Sue Pfefferly. So credit to all of them. Next slide. So briefly, so this going back, so this was right at the beginning of the pandemic. We had actually, I had been working with the Connecticut Health Foundation for a long time. And we had issued an RFP in January to cities and towns in Connecticut to do a different set of community health worker interventions. And then the pandemic hit. And so we pivoted very quickly to change the RFP to say, you know what, you're all underwater. This is an RFP to public health departments in Connecticut cities. And we said, you know what, if you can use community health workers to, deal with the pandemic, go for it, take the money, let's just get it out and we'll figure it out later. And so it moved very, very quickly. And the cities were actually getting calls from people in their communities, people who are really embedded and connected in their communities who wanted to help. And so they were collecting names and doing resumes and building jobs and everything. And they had these folks on board by the time the money came in. So they hired them, gave them some department training, community health worker training, and they were off and running in September of 2020, which was great. And they did some wonderful things. But we didn't have time to develop an evaluation plan during this time. So all of what we were doing that I'm going to show you was developed after the fact, which is not the way you want to do evaluations. Next slide. So these are the 5 cities that received funds and the amounts that they received. Next slide. And then the cities all did whatever they wanted to do with the funds. Basically, they had community health workers who were trained and they could deploy them in a lot of different ways. Some of them used them to support their COVID testing programs or contact tracing. Some were focused much more on education. Some were, and very creative. They would go door to door, go to hair salons, or wherever people were, and spread information. And then some of the cities really focused on helping people to quarantine. And so there was this idea that, okay, people are getting a positive test and they're supposed to stay home and not interact with anyone. Well, what did they need to do that? Well, they need a safe place to stay. They need food. They might need medication. They might need someone to care for their children. There were all kinds of things that people needed. And the community health workers were just as flexible as can be, just talk to people, calm their fears, help them, to understand what was going on, and pulled all kinds of services together to meet people's needs. So it was really a wide-ranging effort with different community health workers doing very, very different things. So that made it very difficult to evaluate. Nonetheless, we tried. So next slide. So once everything was up and running and we felt like people knew what they were doing and they'd been trained and had their technical assistance, we said, okay, what is it that we want to evaluate? And we came up with some goals that we wanted to evaluate the effect of the intervention on controlling the spread of COVID-19. We wanted to measure the economic cost of the intervention. We wanted to measure the ability of community health workers to engage the target population. And we wanted to measure the quality of community health workers' interaction with the target population. So great. How would we go about doing that? Oh, no, stay back. So the first thing that we did was go through the published research as best we could. And there turned out, even that early in the pandemic, there was already a lot of data coming out. And so we relied very heavily on secondary sources. Data provided by grantees would have been great, but they were moving too fast to collect data as they were going. And we had failed to put agreements in place for sharing that data upfront. And so that was quite limited. Data provided by consumers, a couple of the cities allowed us to conduct a survey of consumers with lots of consent and lots of hoops to jump through. But we were able to survey some consumers, and that information is hugely valuable. And then we surveyed the community health workers. So and this is, I'm just sharing you a very, very small piece of a larger study. There's a link at the end to more information if you want it. Next slide. So just very briefly, the survey of the community health workers overall felt that the initiative was making a real difference in people's lives, that it was overall very helpful. There is some variation. And again, you know, the community health workers who filled this out, they were doing very different things. So some of them may have felt that what they were doing was more helpful than others, or that they were able to do it more effectively. Next slide. And then just briefly, the survey of consumers. So we actually had 70 consumers who responded to a survey. And overall, consumers felt that the intervention was extremely helpful, and they were very positive in a number of ways. But then we wanted to ask some really detailed questions, particularly about the part of the intervention that was helping people to quarantine. So next slide. And I'm sorry, I'm going through this so quickly. So generally, overall, the sort of key piece of information here was, and we asked a lot of questions to get at this. This is the overall, the high level summary. Did you, consumer, discuss all your needs with a community health worker? Did you talk about all your medical needs? Did you talk about your non-medical needs? Medical needs might have been getting a doctor's appointment or getting medication. Non-medical needs might have been, you know, getting groceries in so you don't have to go to the grocery store, those kinds of things. And so what percentage of people discussed all their needs, and what percentage of people had their needs met, whether they had those conversations or not? So that is some key information from the survey approach. And then, okay, next slide. So then we wanted to jump into this financial part, which, you know, as I said, we had very little data on the effectiveness other than what was available publicly in the public sphere, or, you know, published research. But we thought, okay, we have to figure out a way to figure this out. And we started with a logic model. So the idea here is, you know, for people who are exposed to COVID, if they engaged with a community health worker, were their medical and non-medical needs met? If they were, they would be more likely to adhere to quarantine and isolation, and they would experience lower infection rates. So that's sort of what we were assuming and working through, and then coming up with estimates of how well that worked. Next slide. And this is a very busy slide that you probably can't see very well. But the way we went about this, given that we had very little data, was that we came up with these scenarios and broke out our group of our sample into these little buckets. So the first branch is, did you discuss all your needs with a community health worker? Did you not discuss any or all of your needs with a community health worker? And the second branch was, if your needs were met, were all your needs met, or were all your needs not met? And then, you know, did you comply with quarantine? Did you not comply with quarantine? So some of this information we had from the survey, and some from the grantees were able to report back on compliance with quarantine. For the people who didn't talk to the community health workers, we had to estimate that based on estimates from the published literature. But basically the assumption was that if people had all their needs met, that 90% of them would be able to comply with quarantine. And if they did not have all their needs met, only about half of them would comply with quarantine. And so we kind of multiplied out all of these percentages and came up with a total number of people who were able to quarantine and therefore reduce the spread of COVID. So this is all, you know, it's a lot of assumptions built on assumptions, but built on parameters that we were able to pull from published literature in order to make a better estimate than we might just guess out of the air. So this was the way of how to approach this in a creative way, but still draw some kind of a conclusion. And the next slide is just, you'll get these afterwards, but this is where all of the parameters came from the published literature, and the citations are in the appendix. Next slide. So basically what we came down to, so this was the conclusion of this, the results of this part of the analysis, that if all all consumers discussed all of their needs with the community health worker and had all their needs, let me say this again. If respondents discussed all of their needs with the community health workers, then we would have expected approximately 6 COVID cases. If they discussed none of their needs with the community health workers, we would have expected closer to 15 cases. And so then the number of cases averted is the 14.6 on this slide, less 5.96, so 8.7, or about 9 cases. 9 cases out of the total that would have been, there would have been results in about 59%, close to 60% of the expected cases were prevented or averted as a result of the community health worker intervention. So that is kind of our, it's not a hard number, but it's a best guess that the intervention was effective in reducing the number of cases. Next slide. And then when we were looking at the costs averted, we found, again, from the literature, that the cost of treating a symptomatic COVID case was about $1,800. The cost of the intervention in this case, it ranged so much from city to city, depending on what they were doing and how intensive the intervention was. And we weren't able to split out the cost of specifically the piece of the intervention that related to meeting individuals' needs. So we didn't actually do the cost effectiveness analysis here, but we could say that the cost of the intervention was several $1,000s per case averted. We didn't feel comfortable being more specific than that. The cost of treatment was $1,800, which was less than the cost of avoiding a case. But that overall, the cost of averting a single COVID-19 case was in the range of a few $1,000s. So that was that. Next slide. So overall conclusions of this evaluation: community health workers effectively met consumers' medical and non-medical needs. Consumers and community health workers believed the initiative was helpful and had a positive impact. Community health workers' efforts helped prevent new COVID-19 cases. And then if you just go quickly to the next slide, has the list of references that we used to draw parameters. The next slide has some links of other analyses that might be helpful to you. And that's the end. Hand it back.
Thank you so much, Catherine, for this presentation. I really appreciate how you just waltz us through the basics of cost effectiveness and then kind of dived into the evaluation part of it. And I generally always find it helpful to have a visual representation of the logic model and also the decision tree to see how it all tied into it. So thank you so much for that. For our audience who've missed the introduction, please note that you can opt for Spanish interpretation for this webinar. You can look for the interpretation option under the More tab in the meeting bar, and both English and Spanish version of the recording will be available after the webinar. Okay, so that's that. So our next speaker is Celeste Lloyd, and a little bit about her. Celeste is a community health worker with WSEP and the CHW Center for Research and Evaluation Leadership teams. As a community health worker, she has been appointed to Michigan's Coronavirus Task Force on Racial Disparities, Michigan Hispanic Latino Commission, and she's currently a fellow with the W.K. Kellogg Global Leadership Network. Celeste has dedicated to community and health advocacy for more than 20 years. She attributes her professional growth to her commitment and surrounding herself with organizations that employ a positive culture and precisely define goals in the advancement of marginalized communities. She lives in Grand Rapids, Michigan with her spouse, her 3 daughters, and first son. So Celeste will be presenting for the next 10 minutes and will be discussing considerations from the viewpoints of community health workers. And she will be exploring alternative ways to tell the story of their impact. So let's give a warm welcome to Celeste.
Thank you, Winnie. Good afternoon if you're on the East Coast, and good morning if you're on the West Coast and anywhere in between. So this afternoon, as Winnie mentioned, I'm going to be speaking around CHW perspective as it relates to this conversation we're having around cost analysis, cost benefit. And so just to give you some insights around where we're thinking at CHWs. Next slide. I'm hoping that after this conversation or this presentation, you'll be able to understand the benefits of measuring CHW contributions, along with CHWs being included and available for developing data, such as developing questions, tools to collect, and the findings. My goal is that you'll also have the opportunity to identify how changing the narrative of CHW advocacy can promote sustainability. Next slide. So we know that CHWs have been around for decades, centuries, depending on what country you're reviewing or evaluating. And so for community health workers, and I'm going to use that term, but just know that also I'm encompassing community health representatives, promotoras de salud, all three of those umbrella topics around CHWs. So we know that CHWs are trusted members of the community. We've heard that a little bit from Catherine's presentation on her results. They do an awesome job around informing and involving community. They assist with dismantling factors that lead to disparities, along with leveraging community power and voice. We know that community health workers are key within integrated care teams. They provide strategies in addressing community needs, and CHWs are a key component to creating equity. Next slide, please. So some of the advocacy work that we want to recommend around CHWs when it comes to this cost benefit or analysis conversation is really looking at how CHWs can be considered more than a pipeline or a tool for reducing cost. We know that CHWs have a large range of opportunities and tasks that they take on. They wear multiple hats. And so they will be adding to different opportunities along with growth within organizations and communities. We know that CHWs are a guide for creating and implementing an equitable community. CHWs really do work hard around, it's less around equal opportunity, but more around equitable opportunities for community members and participants and patients. CHWs are changing the landscape of how we provide care. We saw throughout the pandemic, we see throughout spaces around specialties around maternal child health, chronic disease management, access to housing, food assistance. The CHWs are really doing a range of tasks, and how we provide care looks very different in each one of those specialties, and recognizing that CHWs hold specialties and that not all CHWs are in the same category because of the range of topics that they cover and work with. As CHWs become more efficient in their role, there's an increase in tasks that are not measured. So we know that CHWs wear multiple hats, and unfortunately, as we're talking about evaluation and research, CHWs are not often measured appropriately based off of those tasks. There may be one area or one scope of practice within their role that they're being measured and not looked at compared the spectrum of work that they may be doing. We also want to make sure that it's known that supervisors who doubt the value of their CHW contributions will undermine the work. And so when we're talking and discussing about evaluation and the cost benefit, if the supervisor does not understand the value of the work that the CHW is doing in those various areas, it'll undermine the work and often lead out for evaluation and often lead out where there's ongoing benefits. And then my last point here too is compensating CHWs accordingly. Provide livable wages and reimbursements for unconventional tasks. my kind of leading up to this conversation is you can't really analyze cost benefit if you're not really paying appropriately what CHWs are doing. So making sure that we're addressing all of those different buckets or areas that CHWs are involved with, along with putting a cost to what that savings would be, in return paying CHWs equitably based on the work that they're doing. Next slide, please. And so here I'm providing a tool for individuals who may be wondering, how do I make sure that I'm doing this appropriately within my organization or my agency, that I'm integrating CHWs, that I'm using CHWs in this cost analysis or benefit for my organization. So one of the resources I want to provide is the common indicators grid. I have only common indicator 4 and 5 here. But if you scan the QR code on your device right now, you'll be able to get to our entire indicator grid along with a guide on how to use the indicators. So indicator 4 and 5, and I'll read this very quickly, just the middle column, which is the extent to which a CHW is able to be involved in policy making, both within their own organization and in the larger community on work time or as part of their volunteer commitment. And then 5 being CHW integration into care teams, the extent to which CHWs are members of a collaborative communicative team with other providers within a clinic, school, social service agency, et cetera. And so as we're pulling evaluation, we're, conducting focus groups, where are we addressing our need for our CHWs to have a voice at the table, to have a clear representation of what's being shared or said, and are we acknowledging their contributions when we do our final analysis and research findings or evaluation findings? Next slide, please. And so what's next? What are some of the challenges? If you find yourself in that left column saying, we do have an issue with involving CHWs in evaluation and research, we're not providing a true depiction of what our CHWs do, or we're only giving them snapshots of their work or task, then I'm going to lead you to the right side, which is the opportunity side. As I mentioned, referring to the Community Health Worker Center for Research and Evaluation Common Indicators Grid, along with that guide, we're really going to encourage you to involve CHWs to provide feedback and input, and that CHWs should be included in research and evaluation. They should be listed as contributors, and not just providing information without acknowledging their contribution to the evaluation and research process. And then often traditional work environments are not in alignment with community. And so when we talk about cost benefit and analysis, we're only looking at it from one lens. And so when we include the community health worker, we can make sure that we're looking at a large range. And as we've been discussing, and it's a common conversation around community and different spaces, those social determinants of health, in order to really put a value on that, you need the people who are involved in that work, and along with experiencing those social determinants of health, to outline the need, and along with how to define those for cost. And then my last point really there is, if staff do not understand how they contribute to the goal, you'll lose their impact. And so by inviting CHWs once again to participate in evaluation groups, report outs, and community presentations, in return, you will capture that cost benefit, which will lead to sustainability. We have to have not just the CHWs doing the work, but and advocating on behalf of their role, but really supervisors, upper administrative, and researchers to, along the lines, spread the conversation around the benefit that CHWs bring and how to make that role sustainable and not funded just on grants and temporary programming when emergency needs arise. So with that, I believe I'm done, and I will move it on to the next speaker. Thank you so much.
Thank you so much, Celeste. I think you really zoomed out and brought in a broader perspective on what cost effectiveness would mean, not just in the healthcare areas, but especially in the space that CHWs operate. And I think you brought in the definition for us. So thank you so much for that. I really liked the line where you said, if the staff do not understand how they're contributing to the goal, you'll be losing their impact. So that's amazing. So we'll now move on to our third presentation. I'm sorry, I didn't have my camera on yet. So our final speakers for today are Dr. Gilbert Gim and Joanna Davis, and they will be presenting for the next 15 minutes. Dr. Gim is an associate professor in health administration and policy at George Mason University in Fairfax, Virginia. He is a health economist by training with research interests in disability and aging, community health workers, and healthcare financing. Dr. Gim was previously a senior researcher at Mathematica Policy Research in Washington, D.C., where he conducted program evaluations for CMS, including the Medicaid buy-in program. Dr. Gim received his PhD degree in health economics and policy from the University of Pennsylvania. And our second presenter is Ms. Joanna Davis, and she's a senior program manager with the Institute for Public Health Innovation, based in DC, Maryland, and Virginia. She holds a master's in public health from UNC Chapel Hill's Gilling School of Global Public Health. Joanna comes to IPHI from the New York City Department of Health and Mental Hygiene, where her roles included clinical quality improvement and managing the COVID-19 vaccine rollout in NYC community health centers, where she helped establish mass vaccination sites. Currently at IPHI, she supports community health workforce development and financial sustainability, and oversees public health curriculum development and technical assistance for the local and state health departments. And today, Dr. Gim and Joanna will share their experiences in evaluating interventions and they'll be discussing how to explore sustainable funding mechanisms. So please join me in welcoming them.
Hi, good afternoon. Thank you so much for that wonderful introduction. My name is Joanna Davis, and I thank you to our presenters who came before us. Those were fantastic presentations. And I'm looking forward to kicking off our presentation about explaining our cost effectiveness analysis on sustainable financial models for community health workers. Our project is called Community Health Workers for a Healthy Virginia. And like my introduction said, I work at the Institute for Public Health Innovation, which is based in DC, Maryland, and Virginia. We are the Public Health Institute for that region. This project specifically is based in Virginia. And I am joined by Dr. Gilbert Gim, who is an associate professor at George Mason University and who is supporting the evaluation of this project. Next slide. So today we'll go over what our project is, CHWs for a Healthy Virginia. We'll talk about the two approaches that we have for sustainable community health worker financing in Virginia. Dr. Gim will talk through why evidence is needed for that sustainable financing goal, what some of the key findings and opportunities/challenges have been thus far in our project. And then we'll leave some time for Q&A and discussion, as I think there is general time for Q&A and discussion for all of the presenters who have gone thus far. Next slide, please. So I wanted to give a general overview of what we call Community Health Workers for a Healthy Virginia. In total, our project has two components. The first component, which we call Component B, is where IPHI identified community health worker sites that would help hire, train, and deploy community health workers under various models and settings. Public health settings, community health center settings, community-based organization, hospitals, etc. Some CHWs in those settings serve really specific patient populations, and some have a more general approach. Our project also has another component, which we call Component C, where the primary goal is really to determine a mechanism to sustain the work that's done in Component B and with CHWs sort of at large beyond the short-term grant. So as we know, uptake of community health worker-based community impact models is often limited by these sort of short-term financing mechanisms, often grant-based. So we wanted a way to say, after the length of this grant and after grants generally end that are supporting the financing of community health workers, what is a sustainable mechanism to support community health workers? This would really bolster the retention of community health workers, which our previous presenters, particularly Celeste, has done a fabulous job of really explaining why community health workers are vital in the public health workforce. So we aim to identify who the priority communities are that are benefiting from these CHW interventions, what financing models might look like to support those populations. We aim to pilot those financing models and then to evaluate their pilot. So to say, did this see any return, either clinically in return on investment, in any real impact? We're working in 4 regions of Virginia: Pennsylvania, Dansville, Richmond, Petersburg, Norfolk, Portsmouth, and Southwest Virginia. But our financing models are really specific to 2 regions, Richmond, Petersburg, which is an urban area, and Southwest Virginia, which is a more rural area. Next slide, please. So we aim to support 2 approaches for sustainable financing, and I'll go over them on a high level here. And they are very sort of different from each other and might apply to different patient populations and different community health worker models. The first is called a collaborative approach to public goods investment, or CAPG. And really the way that we aim to emphasize the CAPG model is through collaboration or collaborative funding. The CAPG model essentially takes a social good, so in this case, a community health worker, and the impact of that community health worker, and emphasizes the social service of that community health worker benefits many. So a community health worker benefits many. And in this model, they allow multiple stakeholders who reap that benefit to bid on their services. So these stakeholders, which are oftentimes non-traditional stakeholders, it could be a police department who might reap some of the benefits of having a community health worker within the community. It could be a hospital system or a series of hospital systems. It could be a specific payer. It could even be a philanthropic organization. Any real entity or stakeholder that could see some sort of return on investment or some benefit to having a community health worker within a community has the opportunity to place a bid to say, this is essentially what we're able to support in terms of a percentage or an amount of a community health worker's cost or salary. Oftentimes, these entities aren't necessarily able to hire a community health worker themselves. They might not have funding to say, we can cover really from start to finish a community health worker's salary, cost, fringe, et cetera, but we might be able to cover a portion of it. And that kind of collective bidding, that collaborative approach, is really centered on what this model calls a trusted broker who facilitates that process, takes those private bids, and sort of divvies out the responsibility to provide that upfront cost, and then also ideally the savings that they get in return. So it's really a coordinated public approach to financing. And it shows what impact a community health worker, as an example of a social service, has within the community. In the second model, which is called outcomes-based financing, or the OBF model, this is really where the funder, which is often a Medicaid managed care organization, an MCO, and the CHW hosting site sort of agree together on the outcomes that they care about, the outcomes that the CHWs are working towards, the outcomes that sort of meet the needs of the MCO, and they create a contract within the MCOs and within the CHW hosting site that allows for them to share the savings once they provide that upfront capital, if these outcomes are met. Again, the funders in this model are Medicaid managed care organizations. So this model is generally more applicable to a CHW host site that has patients that are insured by MCOs. So again, these two models are sort of varied in their approach, might be varied in the types of models that they're applicable for, in the communities that they make sense in. So we wanted to explore to what degree do these models make sense in our rural and urban area, based on what the CHWs are specializing in, and what patient populations they see. And then we wanted to evaluate, will this pilot be successful, and to what degree, essentially, will this work? And now I want to pass on the presentation to Dr. Gilbert Gim, who will explore the case being made for sustainable financing and the work that we're doing to evaluate it.
Great. Next slide, please. So thank you, Joanna. I'm Gilbert Gim, and I'm serving as the Component C lead evaluator for the CHW's For a Healthy Virginia project. We just wanted to share briefly with you some of the opportunities, challenges, and lessons learned. One key question for our team is why do we need evidence for sustainable CHW financing in Virginia? Celeste did a really nice job of sort of highlighting the challenges of short-term grants and how it can make it difficult to retain community health workers. The first and most important reason for this evidence is to support the growing number of community health workers in the Virginia workforce. So here, using data from the Bureau of Labor Statistics, we found between 2019 and 2022, an increase in the number of CHWs employed from about 850 statewide to 1,440 CHWs. And nearly a third of those CHWs were employed by hospitals, or 460 CHWs employed by hospitals. So this is a really important source of CHW employment growth, not only in this year, but in the years to come. A second important reason for evidence is that it's needed to build the case for CHW investments from skeptical stakeholders. And this is the link to cost effectiveness analysis and cost benefit analysis that you've heard earlier. So we recognize and will delve into the sort of financial aspect of cost effectiveness analysis that you heard from Catherine earlier. We also discovered from our interviews that this return on investment, or ROI evidence, is necessary for many stakeholders and decision makers to make this investment, but it's not sufficient. So often qualitative stories of CHW impacts in the local community matter a lot, and it can be one story that influences a leader. It could be a policymaker, it could be a healthcare executive, someone responsible and has the resources to invest in CHWs can value qualitative stories as well as quantitative evidence. We did find in the literature that there is roughly a break-even point of about $40,000 to $50,000 per year in direct salary costs for a community health worker. So in Catherine's model, this is kind of the assumption in the denominator of the cost of an individual community health worker. So at first, it might seem this is a very straightforward exercise, but it's quite difficult because of the absence of evidence from the literature and also the difficulty of obtaining data. So some of the challenges in doing a cost-effectiveness analysis, first, multiple stakeholders have very differing views on meaningful outcomes. So we'll share an example, let's say for healthcare, where if a community health worker has an direct annual salary cost of $40,000, and let's say the average total cost of a hospitalization is $10,000, then a CHW investment would pay for itself as a minimum if that CHW is associated with avoiding 4 or more hospitalizations. That's a very simplified point. But for other stakeholders, they may value school days attended. They may value work days attended, as you saw in the example of social return on investment. So we have to really kind of look at a variety of different outcomes and focus ones that are going to provide the greatest impact. Other challenges include attribution to the CHW versus the team. Celeste presented one of the common indicators, number 5, as having a CHW in a team. We think this is an important model, but in terms of attributing the impact of a CHW, it can make it a little bit more difficult in a formal analysis. And then lastly, data gaps. That's the biggest challenge we've encountered on our project, obtaining different variables from different stakeholders. And then the last point is the time frame. Most cost-effectiveness studies use 1 year or less as a time frame. We found that it often takes more than 1 year to see the impacts of CHWs. In part, that's because of the training involved with CHWs. There may be staff turnover. CHWs also build trusted relationships in the community, and that can take several months. Next slide, please. So our 2 guiding research questions were, what were the key successes, challenges, and lessons learned in developing these models in the 2 regions? And second, to what extent did the CHWs reduce avoidable ED visits and hospitalizations? And more importantly, did this reduction exceed that break-even threshold of $40,000 per year? Next slide, please. So very briefly, just some highlights and key findings from our site visits and interviews. First, we found that the roles of community health workers and their scope of activities are often tailored to the specific goals of a CHW employer. And what we mean by that is some CHWs are hired and employed by hospitals or health systems, very much kind of geared towards reducing avoidable hospitalizations or ED visits. But on the other hand, right, we may have CHWs hired by public health districts where the focus may be on COVID-19 vaccinations or sharing information. Second, although we've seen growth in the number of CHWs, there's 2 really important reasons why sustainable financing is still needed. The first is there's quite limited awareness of the unique role that community health workers serve. And maybe not so much in kind of within this audience, but for healthcare providers, physicians, leaders, allied healthcare workers, nurse case managers, and social workers in particular, who may be territorial or engage in kind of a turf war of their scope of activities. If there isn't support at that level, that can make sustainable financing quite challenging. And CHWs generate positive spillover benefits across the community, not just to the hospitals, but to schools, to law enforcement agencies, et cetera. So it is really important. And then third, because of this challenge, we initiated a data matching pilot with one health system in Southwest Virginia. And this is going to allow us to compare patients touched by a CHW and their healthcare utilization versus a control group of patients who are untouched by a CHW. Next slide, please. And so finally, some of the lessons we learned. First, building relationships with financing partners is a slow and challenging process, but a necessary step in this work. The second, which is applicable to all the states and the audience, we did notice that some Medicaid managed care organizations or payers already employ individuals who have a job title that has CHW in it. But these individuals don't really perform many of the core activities of CHWs, such as developing trust in a local community. So instead, these individuals are serving more as outreach managers, doing follow-ups with specific members in the area. And then third, as I mentioned, sustainable financing depends on the awareness of community health workers and buy-in from policymakers, leadership, such as hospital executives and physicians, and especially nurse case managers and social workers. On a positive note, I did want to mention that Medicare Part B payment reform is going to take effect in 2024, where some community healthcare worker services will be billable by health systems and clinicians. And we see this as an opportunity, not only for financing in the future, but also building greater awareness. So thank you for listening to today's presentation. And now I'll turn the mic back to our moderator, Winnie, to facilitate today's Q&A discussion.
Thank you so much, Dr. Kim and Joanna, for the presentation. The how-tos, the lessons learned, the challenges, and the opportunities present a very comprehensive learning for us. All right, so we're going to have a moderated Q&A session for the next 20 minutes. And please feel free to put in any question you might have in the Q&A feature. And let's go. So we shall be addressing most of what you've asked in the chat. In the interest of time, we'll keep it to 20 minutes. And in case we don't get to answer all your questions, we'll put it in a separate document and send it along with the additional resources from today's webinar. We'll try to make sure that everyone's questions are answered. Okay. So the first question is from one of our participants today, Taylor Holland, for Celeste. So Celeste, here's a question. Do you have advice on how to move forward with community health workers having formal specialties when there are internal hesitations?
Yeah, that's a great question. So some of the work I've done with organizations is really cleaning up job descriptions for CHWs, making sure that there is a foundation component of the CHW role, and then really digging deep into those job descriptions around the specialty. For example, if you have a CHW or if your team is CHWs who do maternal child health, making sure that you're outlining what that actually looks like. What is the population demographics? What trainings or specialties are they expected to have or learn? Are they CLCs? Are they taking, different courses that specialize with OBGYNs? Are they doing contraceptive trainings? So all of those different trainings that might be in that area of maternal child health, making sure you're capturing that in job descriptions. So that way, when you're advocating within your organizations or agencies around the CHW role being more than just that blanket statement, you have some supporting data and some supporting information that goes along with that role. And no different than if you have CHWs who are working in the cardiovascular health sector, and housing and healthy homes and career advancement, you would want to make sure that your job descriptions are clear and concise, and that you have an ongoing list of continuing education or trainings that you're expecting your CHWs to complete. Not only does it help to promote that specialty within your organization, but also gives you the opportunity to advocate on behalf of their salaries and their livable wages, and that you're respecting that the role is just more than just a blanket statement. Often when we see specialties, we see opportunities for additional funding and for for pay. The same with our bilingual CHWs.
Thank you so much, Celeste, for that. We have a question from Sarah Wagner, and I think it's for the whole panel and anyone who's interested in take this up. This is the question is, have other 2109 recipients conducted an economic evaluation? And if so, would they be willing to share their experiences? And she also says that she's interested in conducting one for their program and would like more direction on where to start. So this is for anyone who would like to take this on.
Well, I can, I guess, start off. And maybe one question that might be helpful, Sarah, is to sort of clarify what you mean exactly by an economic evaluation. So you've seen a couple of examples, a cost effectiveness analysis, which is really looking at the return on investment from investments in community health workers. Other types of evaluation, of course, could be more holistic in looking at these other outcomes, tied to a social return on investment. So yeah, depending on the scope of analysis that you'd like to cover, what sort of outcomes you'd like to consider, I think that's an important area to start. And as we mentioned, right, because there's so many different outcomes, as Catherine stated, really trying to hone in where you'd like to kind of focus your efforts, whether it's financial returns or costs avoided, whether it's increased cancer screenings or vaccinations, or whether it's other types of impacts, school days, school absences reduced, work absences reduced. Looking at outcomes, I think, is a really important place to start. And then a second area is really thinking about your audience. So of course, our evaluation in developing sustainable financing models is important in and of itself, but we're really looking ultimately to try to influence policymakers, other stakeholders, and healthcare CEOs who are on the fence, right, who have a lot of resources, but are hesitating, right? They're sort of waiting to say, I don't understand exactly what a community health worker does, or we have nurse case managers and social workers. Aren't they the same? No, they're not, by the way, but that's part of our evaluation as well, really thinking about that audience. So I would say, yeah, let's start with thinking about outcomes and who is the audience for your evaluation. So it's kind of hard, kind of begin with the end in mind. You finish the report. Who ideally would you like to have read this?
Thank you so much, Dr. Gim. That was very helpful. Yeah, we're just thinking of our different options going forward, and definitely that was really, really great advice. Thank you so much.
Thank you so much, Dr. Gim, for your answer. Our next question is from James Day, and it's also for Dr. Gim and Joanna. So he asks, what would have made your evaluation in Virginia better? How would you take your evaluation to the next step?
I guess I can start with this as well, and then I'll turn it to Joanna. I think one of the biggest challenges has been access to data. We have been fortunate that there are two components with our project. Component C focused on the financing models, and component B, which has really helped in facilitating the training, recruitment, and looking at ways of retaining community health workers that have been hired under the grant. So we have a lot of wonderful data about tracking the experiences of community health workers when they started, if there's been turnover in the first year, sort of are there attributes associated with that? Is that occurring in one particular region? That doesn't happen to be the case. So information coming directly from community health workers, that's been fantastic. They've been really eager to participate and be involved in the research. Our major challenge has been accessing things like hospitalizations, ED visits, et cetera. And we have been able to obtain access to an all-payer claims data set for Virginia. However, the piece that we're missing is identifying patients touched by a CHW and patients not touched by a CHW. That is not systematically recorded by hospitals or health systems. And that we have to go directly to a health system that has employed CHWs and ask them to literally kind of flag those patients. So I would say, kind of going back to the beginning, James, if we had thought about this sort of starting the data use agreement process earlier, it takes at least a year to get the cooperation of multiple entities, particularly healthcare systems where they're concerned about data privacy, HIPAA violations, et cetera. CHWs are trusted frontline public health workers, and it takes time to build trust. I would say the same thing for evaluators in terms of accessing data. It takes a while to build trust. So yeah, going back, we would have probably started with developing this data use agreement right at the beginning. But thank you for that great question. Joanna, your thoughts on this question?
Yeah, I was nodding along to what you said, and wanting to piggyback as well. I think the data use agreement process, certainly, and then in addition to that, the potential, we may have had in our minds to get even more granular to what some of that data on CHW effect looks like. So for an example, what services did the CHW refer to? Would there be a way to say a CHW that referred to a shelter, housing, somebody who is housing insecure, if they refer to housing services, that had a direct effect on ED utilization, that sort of thing. But because there isn't necessarily that granular data to say, let's say Joanna Davis, CHW, referred patient Jane Doe to service X, Y, and Z, and a similar patient, John Doe, was never referred, looked clinically similar, but was never referred to services X, Y, and Z, could those two patients be matched? We're doing something similar with patients who are touched by a CHW or not, but I think the ability to get into that really granular data would be really interesting.
Thank you so much for your answer. In the interest of time, we'll quickly move on to the next one. This is for Catherine. Catherine, you spoke of drawing on existing research. Can you talk to us a little about any other sources of data that are collected that could contribute to assessing the impacts of CHW interventions, like instead of needing to do a whole cost effectiveness analysis?
Oh, and I didn't even see that. I was thinking that we were going to a different question. So there is a ton of data out there. I'm just going to say there are a lot of really good evaluations of community health worker services, of whatever intervention you're trying to look at. There's probably a meta-analysis that's already been done. My recommendation is just before you do anything, do a literature search and see what's out there, see what you can build on. So that's a pretty generic answer. But always start with what other people have done before, because there's so much that you can build on, and there's no point in reinventing the wheel every time.
Yep, agree about that. Our next question is for Celeste. How can success stories complement evaluation that focuses on monetary outcomes? That's a good question.
Yeah, and I think Dr. Gim actually hinted on that earlier in his presentation around taking that quantitative and qualitative data and putting it together and really packaging that well. So often CHWs are not asked what worked or what didn't work. Where can we make enhancements? Where can we make changes? And so really documenting, we heard it's hard to get back that patient or that participant to provide feedback. So having CHWs get that information on the spot, making sure they're doing, they have satisfaction surveys, they have opportunities to check in with participants so participants can give feedback on what's working and what's not working, and then putting that together with the data that's being, collected on the back end through documentation and reporting. So I think that's the key. That's where I've been able to be successful, where my team has been able to be successful, is really taking firsthand the participant or patient's experience and then putting that together with the patient data that exists within Epic or within whatever tracking system you might be using to report out on. And I just want to add really quickly to Catherine's last response around starting with literature, but also making sure you go back to community and that you bring community in for input, because communities are also exhausted of being over-researched and over-evaluated from past, opportunities that have occurred either the year before or previous year. So just making sure that as you're doing that lit review, that you're bringing community into the fold to ask them how would they like to see your project or whatever programming you're thinking of, next steps.
Yes. Okay, so the next question I think is for Celeste and the entire team, and I think this is a question that we've all wondered about it. So the presentation kind of speaks to a tension between like measuring the value of CHW's interventions in order to make the case for sustainability and the inequitable burden of proof that this places on the CHW workforce to constantly justify themselves. So do you envision a point in time when CHW interventions do not require such justification?
We would hope that would happen today, right? Like we would wake up tomorrow and CHWs wouldn't be making this case of why I'm important and why my role needs to be funded in overhead budgets and not just through grant opportunities. I think we're getting there as more states are looking at Medicaid reimbursement for CHWs. There's definitely an interest and awareness that CHWs are doing great work. But we also know Medicaid is not going to pay CHW salaries. It's not going to cover all of the costs or the fringe rates that it come with CHW roles. And so I think it goes back to how do we create advocacy within organizations and agencies to say, they have a respected role, they can show that there's benefit. This really has to be led by administrative, it has to be led by the CEOs, hospital admins, to make sure that they're advocating at that level and that it's being changed across the board. I think that's part of the obstacle. And I think Dr. Gim hinted on this, that not too many people still within hospital systems or organizations understand what the actual role of a CHW is. And so we have to do a better job as CHWs and CHW allies on really putting definition to that role so that we can continue to advocate and then move throughout the different areas within our systems. And then, yes, hopefully we wake up tomorrow and CHWs are no longer on this grant cycle or, this plea of we're important. It's because they know it.
Would anybody add to that? Yeah.
Sure, I can jump in, building on Celeste's comment. Yeah, I do think having leadership recognition of CHWs is really important. I mean, in the short run, because of the limited awareness, we're still in this time where repeating, right, the value of community health workers to different stakeholders, right, based on outcomes that are meaningful to them is really important. I'm actually very optimistic with this Medicare Part B funding change that if we were to reconvene about 5 to 10 years from now, I would say every hospital CEO will know what a community health worker is. And there, the challenge will be convincing allied healthcare providers, physicians, social workers, nurse case managers, that community health workers have a unique role, right, because of their trusted relationships in the community, their contacts with community-based organizations, that adds a lot of value for the health system as a whole. So I'm actually very optimistic. I think 10 years from now, we're going to have much more awareness within the healthcare system. But for other settings, that's going to continue to be important, right? So for schools, for mayors, for policymakers, they still don't really understand what community health workers do. But I am, again, very optimistic. Again, I think 10 years from now, many healthcare leaders will at least have an idea of what a community health worker is. And the challenge there is going to be sort of integrating them within the team. So there's an optimistic note.
Thank you, everybody, and thank you so much for your presentation and your time, and thank you to the audience for attending our webinar. I think that brings us to the end of our Q&A session, and it was such an honor to host and be like a moderator. This was my first time, and I really enjoyed it, and I look forward to doing more of it. And I'll now pass it back to our host, Elizabeth.
Great, thank you so much. Thank you, Winnie, and thank you all of our speakers for your time and your expertise today. We're really grateful and lucky to get to hear from you today. 3 quick items just to end out our webinar today. First, I am going to share in the chat here just a reflection question for everyone to kind of take with you. How have or could you include key end users, including the community as Celeste recommends, throughout the evaluation process and not just sharing the information from the end report? What was or would be gained? So just a question for you to take with you as you digest the information from today. Next, in the spirit of evaluation, I am going to launch a quick Zoom poll to get your feedback about today's session. I'll go ahead and launch that now, and I'll keep that up as I round out the rest of our information for the webinar. Go next slide. And so I wanted to share 2 additional opportunities. One is coming up tomorrow. It is Envision Equity is presenting Medicare CHW Financial Sustainability Strategy, which is very relevant and related to our conversation today. I will go ahead and put the registration link for that in the chat. We also have coming up next spring, April 16th through 18th in Spokane, Washington, the CHW Sustainability Summit, which is co-hosted by Envision, ASU, and WSEP. This summit will offer recipients of CDC's CCR-2109 program the opportunity to showcase their work and strategize together about how to continue CHW programs in the absence of CCR grant funding. All CCR-2109 recipients are invited to send up to 6 attendees. The initial registration form will be sent to recipients in January 2024, so please keep an eye out for that. And that concludes our webinar for today. Thank you all so much for your participation and joining us for this important conversation. We're very grateful to share this space with you, and we look forward to doing so in the next opportunity. We will share the recording of this webinar alongside the slides and some additional resources via AMP, and so you can access that there. Please remember, if you are a 2109 recipient, you can also request technical assistance on this topic or other evaluation topics through your TA liaison. Thank you and have a great day.